Hi, everyone. Welcome to our second session of our supported decision-making training, educational training series. Just a couple of reminders as everyone is joining in is that we do have live interpretation into both English, we're speaking in English, but we have live interpretation into Spanish and Korean as well. So please select your language. You will be able to find it at the bottom. There should be a globe that says interpretation, and you can select English, Korean, or Spanish. If you don't see the globe, select more, and then from more, you'll be able to see the interpretation globe. Instructions in both English and Spanish can be found in the chat as well. Again, for folks joining on, we do have live interpretation into Spanish and Korean, so please select your language. If you are listening in on English, please also select English so you're able to hear any questions that are interpreted as well. But thank you everyone for joining our second session for our supported decision-making educational training series. We're really excited to be able to bring everyone here today as we talk about supported decision-making in healthcare, as well as supported decision-making in living independently or living without parents, away from parents. And so before we get started tonight, we do have a couple of announcements. Our first announcement is if you want to continue learning about supported decision making and connecting with other family advocates, self advocates, and professionals about supported decision making, please join our Supported Decision Making Connect series. We just started that this year, and it will happen the last Monday of every month from 4 to 5:30. Instructions to register will be put into the chat. And every time we might have a presentation, sometimes we might have guest speakers, sometimes it's just going to be almost like a support group for us to talk about supported decision making, the wins and the challenges as well. During that series, we'll also have Britt Bellwine, who is a lawyer working for the ACLU, who is knows about supported decision making and is working to help folks exit conservatorships. And she'll be there to answer legal questions folks may have about supported decision making as well. And with that, we will go ahead and get started with our session today, starting with supported decision making in healthcare. And love to have Brian introduce himself and get us started.
Thank you so much, Vivian. Well, good afternoon or good evening, everyone. Thank you so much for being here tonight with us. My name is Brian Gutierrez. I am the project manager for the Outreach and Leadership Training here at Disability Voices United. I am also a self-advocate living with spina bifida. For accessibility purposes, just to provide an image description of myself, I am a Hispanic male wearing a charcoal gray t-shirt, brown skin, black mustache, and dark black hair. So thank you again for being here today. Supported decision making has been really impactful to me as a person with a disability. Supported decision making really helps me to make decisions with the support of someone that I trust. One of my earliest experiences using supported decision making was back in 2004 when I was about 14 years of age. During that time, I just began my freshman year in high school. However, I was already thinking about what life after high school could look like for me and how independent that I can be. At the time, my urologist recommended an integrated enema program for my bowel management care. So I had to decide whether to have an integrated enema program, which helps to improve with bowel continence. Now, many people with spina bifida, like myself, experience both bowel and urinary incontinence. So managing my bowel care is really important to me in my essential daily life routine. So when my urologist explained the procedure, it wasn't just about a conversation with my mom, who is my primary supporter. I was also included in discussion as well. So My urologist and I, we talked about the benefits, the risk, and what my daily routine might look like after the procedure. Despite that, my mom faced a language barrier in communicating with my doctors. Thankfully, there was an interpreter at the office at the time, and my mom helped me to understand information and to think through the decision. So, like I said, my mom has always been my primary supporter, and she has helped me talk through many healthcare decisions throughout my journey. So, after talking with everything with my family and my urologist, I made the decision to move forward with the program, which really has been a life changing for me, and that really improved my quality of life as a person living with spina bifida. And so that experience was super important to me, and it really showed me early that my voice really matters in my healthcare decisions, and it helped me build confidence and also my self advocacy skills to really ask questions, but also to speak up for my needs through my medical appointments. But as I got older, I also continued to use SDM in managing my healthcare. Sometimes those decisions were about routine procedures like MRIs or colonoscopies, where I wanted to understand why something was being recommended and what that experience might look like for me. And I also used tools along the way that help my communication more easier in communicating with my healthcare providers. So, for example, when I see a new doctor or when I'm getting ready for a procedure like a colonoscopy, I always bring something called a healthcare passport. And so the healthcare passport is really a document that includes important information about my medical history or my disability, my medical needs, and how healthcare providers can best communicate with me. It also makes sure to um, it also makes sure that doctors understand what my needs are and how to advocate for myself more effectively. However, I do want to share that about 2 years ago, I faced one of the most healthcare decisions of my life, and that is when I was diagnosed with early stage colorectal cancer. And so that diagnosis came right after my first colonoscopy, which they found a cancerous polyp. And after reviewing my colonoscopy report and my medical history, after a week after my first colonoscopy, I was supposed to go under an imaging procedure to determine the exact stage of my cancer. And when I was getting ready for that procedure to determine that my stage of my cancer, my GI doctor recommended an endoscopic resection procedure and believed that I would be a good candidate for it. And hearing the word cancer was incredibly scary and overwhelming for me, with a lot of new medical information, new treatment options, and even decisions that needed to be made. And so this was a moment where I used supported decision making, which again really has been an important tool for me in my journey. So I talked with my mom about the procedure, but also I talked with my doctor to really better understand what the procedure would be involved or what that looked like for me. And so those conversations really helped me process everything that was happening. And my mom helped me through the information and even ask questions. And she didn't even make the decision for myself. I had to make that decision for myself. And after learning more and talking things to my mom, I decided to move forward with that endoscopic resection procedure, which ultimately was the right decision for me. And after the procedure, my doctors, my care team, continued to monitor my health closely. And so I was followed with blood work and MRI scans, and those tests showed that the treatment or the endoscopic resection procedure was successful, and I was now in remission. And I am very grateful to say that I am almost in 2 years in being in remission. And so that experience for me just showed that how supportive decision making can really make a difference in someone's healthcare journey. And so when things get overwhelmed, having trusted supporters really just makes a difference and helps us to slow down things and understanding information, and also just to make decisions that are right for you. And so again, supported decision making is really an empowering tool that you can take, right? No matter what your disability is and no matter what your lived experiences is, supported decision making can truly make a difference in your healthcare journey. And so, with that being said, Vivian, I would like to pass it back to you, and thank you again for allowing me to share my SDM story.
Thank you, Brian, for sharing your story. As we continue talking about supported decision making in healthcare, I'd love for Miguel to join us and Miguel to introduce himself and share his supported decision making story before we go into more technical aspects of it.
Absolutely. Thank you so much, Vivian, for having me. And I want to thank everyone that's here for being here as well. My, well, I'll start my supported decision making story by sharing that back in back in 29 back on December 31st of 2019, I suffered a series of three strokes the morning of. The third stroke left me without the ability to be able to talk, walk, or pretty much do anything for myself. Since that day, I'm happy to report that I have recovered until to about 95% of my abilities to be as independent as I can. However, along that journey, part of uh, part of what we wanted to do was to find out what had happened. So my general doctor recommended me to a specialist, a neurologist, which I had never seen before. So I went to go see him, and he recommended an MRI. I had no idea what an MRI was, so I agreed. Once the appointment came and I went to go get my MRI done, I went into the lab, and upon getting there, I was told that I was going to have to lay down inside a tube and stay still for about 20 to 30 minutes possibly. Um, I did not know that. I was not explained to that, and I have cerebral palsy. For me, staying still for 2 minutes is almost impossible. So once I heard that I would have to stay still for 20 to 30 minutes, um, right away, it was a no-go. There's no way that's gonna happen. So, in speaking with that technician, I learned that a CAT scan or CT scan, I'm not sure which one it is, would accomplish the same thing. Um, I went back to my doctor and shared that information, and we went forward with that CAT scan instead. But in the midst of that process, taking into account the amount of time that it gets to have authorization to prove is enormous. I pretty much lost about a year with with what could have been prevented with a very simple 20-second conversation. Had I known that an MRI was going to require me to stay still for 20 to 30 minutes right off the bat, I would have told my doctor that that was not going to work, and we could have discussed what the alternative was, at which point I'm sure that a CAT scan would have came up and would have prevented all that wasted time. Um, and I go back and now I think about when I started practicing supported decision making, and without realizing it, I started practicing it at a very young age. I remember being 12 years old, and because of my cerebral palsy, the way that I was walking at the time was going to in the future hurt my legs, my joints. So the doctors recommended I wear braces from my feet to my knees. These were, I don't know if some of you are familiar with these kinds of braces, but these are plastic braces that are meant to hold your foot in place, which I understand the concept of a brace and what it's supposed to do. However, whether you're forcing my body to stay in a certain position or not, my body's gonna move and it's gonna wiggle, and it doesn't matter how hard you try to force me to stay in one position, my body's still gonna move. So even though I had the braces on my feet were still wiggling and moving inside of a brace, causing me pain. Enough pain to where I went from walking the way that I could walk to not wanting to walk at all, to not wanting to wear the braces at all. So, in speaking to my parents and my support team after months, and I'm talking months because I was 12 years old. So, as many of us believe, the doctor knows best. So my mom really wanted me to wear these braces, and she would make me wear them. But when I would wear them, I was in severe pain to the point where it doesn't matter if my walking improves or not. I just want to walk the way that I can walk and not be in pain. And after understanding that, and it took me a while to convince my parents of that. But once they got it, once they understood, it made sense to them. And that's when we went back to the doctor and we let him know that these braces were not gonna work and that I was willing to suffer whatever consequences may come from not wearing the braces as they may be. Now, close to 30 years later, I'm still walking. I don't walk. I don't walk as straight as many of you, but I still walk. And I still need to to where I need to get to as best as I can. And I think that's the whole point of living our own independent lives is to do what we have to do as best as we can. Um, and that's my story of supported decision making. Thank you.
Thank you, Miguel, for sharing your story of using supported decision making and again, sharing how you use it at such a young age and how important it is for self-advocates or to be involved in their medical decisions to really, they know their body best and to be able to be a part of that decision making when you're in that room is so important. Next, I'd love to bring Dr. Linda Deemer to come and present and talk more about the risks of conservatorship, why supported decision making is so important, and supported decision making in healthcare. We do have slides for this section, and so we are going to share the links to the slides in the chat, but we will also share them on the screen. They will be both in English and Spanish. So first, we'll share the Spanish slides. And then I will share the English slides. And so you will be able to toggle between English and Spanish slides to whatever your preference is. So we'll go ahead and start sharing the Spanish slides.
Thank you, Vivian. Um, I don't speak Spanish. I'm sorry to say. So
And then we'll
I
go ahead and share the English slides now too.
terrific. Thank you. I thought I was going to go through the whole thing. Anyway, it is really an honor to be here. My name's Linda Deemer, and I have tremendous respect for Judy Mark and for Vivian Doe and all that they have done. I want you to know that Judy Mark was instrumental in making SDM possible in California by getting legislation passed through an enormous amount of very strategic and intelligent work. And I'm greatly indebted to Judy for that. Um, and one of the reasons I'm here or my qualifications are that I have two family members that are on the autism spectrum that are adults, and one of them is conserved, which you might find somewhat puzzling. And I'd be happy to explain that and why that's part of the reason that I am so supportive of supported decision making. My other qualification is that I'm a professor at UCLA. I'm in the departments of medicine, a division of cardiology, and the departments of physiology, bioengineering, and disability studies. For accessibility purposes, I'm going to follow Brian's uh, model and try to describe myself and what you see on the screen. I'm a Caucasian little old lady, or you could say a frumpy professor. I have glasses, short brown hair, white shirt, navy blazer, and what no one can see is that I have a small dog at my knee begging for attention. So moving on to the slides, I'm going to ask for the next slide. And so this is about why there's pressure to conserve, and I experienced this myself. The schools and the medical offices, regional center, many different resources that families depend on tend to pressure families to conserve their loved ones. And that can often be for their convenience. It turns out it's easier for schools to work with a conservator instead of having to, actually have discussions with the self-advocate. They think it's easier in any way, in any case. They find it, they can use jargon and things like that. So it's largely for their convenience, for doctors' offices, the so special needs attorneys, perhaps, many sources of pressure. There are serious risks of conservatorship. The biggest myth I'd like to eliminate is the myth that if a if a family member gets conservatorship, they feel that it gives them the authority to protect their loved one. And what I think most people who seek conservatorships don't realize is that it actually gives the power and authority not to the conservator, but actually to the court. It turns out that the court can order a conservator to do things to the conservatee that neither the conservator nor the conservatee want. And what that means, for instance, is that if you have a vulnerable loved one that you wish to protect, and let's say it's perhaps a young woman and you want to protect her from, say, a predatory other relative or some other individual that she may be afraid of, and you get a conservatorship, what can happen is that that other relative can actually go to court and demand to have visitation with the conservatee. And they can actually get the court to order the conservator to bring the conservatee to that relative's home for unsupervised visitation, for instance. And so it really takes the power away from a parent and gives it to the court system, a legal system that's quite vulnerable. If a parent refuses to carry out the orders, the court can then replace the parent with a professional conservator. The professional conservators are variable in their qualities, but they may take advantage. Professional conservators are in a position where they could take enormous advantage of the absolute power that they have over both the family member and the conservatee. Because they can control the conservatee and, for instance, locate them somewhere other than take them from the home and locate them somewhere else and limit the family members and the former conservators' access to, say, 1 or 2 hours on a weekend day. And these are things that I've seen in person. There are quite a number of cases in California where very serious problems have occurred. And there was one family that was getting billed $10,000 per month, not for care, but just for the legal expenses that the conservator was billing, the professional fiduciary conservator. So it can become a vicious cycle and a very bad decision, and it's a permanent one. Very rarely is conservatorship reversed. If Britney Spears could do it with a lot of help, but it's a very rare thing to have it reversed. Interestingly, if you do get it reversed, it's called a restoration of rights, which actually should give you insight that the name conservatorship is probably incorrect, that getting conservatorship is a removal of rights. It takes away all human rights and gives it to another person who may not have the best interest of the conservatee at heart. Lastly here, it's important to remember that capacity and support needs change over time, and therefore a person who may seem very in need of a conservatorship and need of protection may 10 years later not need it anymore. And so you really don't want an irreversible decision to be involved. Okay, next slide. Okay, so as many of you may already know, supported decision making involves the self-advocate to choose supporters to help make decisions, to help them understand, consider, and communicate the decisions, not to make the decisions for them. So if a doctor uses jargon, a supporter could sort out what the jargon is and explain and indicate the impact and the consequences. The the supported decision making allows flexibility so the self-advocate can change their minds and as to who their supporters are, and they can use multiple supporters, one for financial, one for educational, another for social, depending over time what they need. And I would point out that all of us use supported decision making all the time because we all need help making decisions that are beyond our knowledge, like handling taxes and handling, going to the doctor is a form of supported decision making. Formal documents that you can put together are a release of information that addresses the HIPAA laws that's for privacy of your medical information. And so in a HIPAA authorization, you can give authority to a supporter to have access to your medical records and to hear what the doctor says. There's also an advanced medical directive that's a good idea to get, which basically indicates your wishes and to give someone authority to make decisions in case you're unconscious or completely incapacitated and can't communicate anything. So having those two documents can be extremely helpful. Next slide. So these are known as substitute decision making, not to be confused with SDM and supported decision making. In substituted decision making, you can have the in substitute decision making, somebody else makes the decisions. And that's like in a healthcare power of attorney, an advanced care directive, where you can identify a person who will make decisions for you. So a durable healthcare power of attorney is something that lasts beyond your incapacity and it allows that person to make your decisions. If you don't have that, the law uses a next of kin process where they have parent or child and then siblings. There's a priority order of who would get to make the decisions if there's not a healthcare power of attorney and if you're incapacitated. Next slide. And so these are what the kinds of forms would look like. These are examples, I believe, from the ACLU. It's, yeah, from the Disability Rights Program, and it's adapted from the probate law. This is an example of what this durable healthcare power of attorney would look like. And, everybody can get these. In fact, most people my age do have these things already worked out. The
Yeah.
HIPAA agreement allows you to share your medical information. They can talk to the doctor and see the records and, communicate, find out, what's going on. So those are valuable. Next slide. How many minutes do I have, Vivian?
You have another 10-ish minutes. And I'll
Oh,
jump in to say that all of these are available in our handbook and they're available in plain language as well. And so we'll put in the chat the link to our handbook, which has all of these and has them translated as well.
great. Thank you. And did you have any other comments while I've got you
No,
engaged?
that was the main comment for now, just so that folks have access to that resource. Thank you.
Great. Just please interject anytime. Okay. So when you're going to use supported decision making, and I'm going to be talking both to the supporters and the supportees, self-advocates and family members or whoever, close friends. To get ready when you're going to do SDM is to talk over what is going to happen at the visit and what's to be expected and what procedures might be done. Preparing in advance makes a big difference so that it's easier and faster to get through what will be happening at the visit. As you all may know, it's really hard to get any time with doctors anymore. And they're all pressed for time. They're required to minimize the time with patients. Like 15 minutes is a typical thing that doctors are allowed to have. And so they're going to be in a rush. Oh, what happened? Oh, there it is. Okay, that's the handbook. So it's very helpful to plan ahead and already be thinking about it and deciding you know, starting making decisions even before you get there, and deciding, um, you know, what kind of support is going to be needed, depending on whether it's just a basic procedure or whether it's a routine examination or something complicated like Brian and Miguel were talking about, surgery or procedures, and what kind of help you need, like holding still. A lot of people need to take some Valium before they get an MRI because they can't hold still either. It's a common problem, or they get claustrophobic. But discussing exactly what goes on in the procedures, and often you can read about these in advance online. Next slide. So as Brian was mentioning, a healthcare passport can be extremely valuable and it can take many different forms. And this is an example. Vivian, is this in the handbook as well?
Yes, this is also available via our handbook. There should be a link to it, as well as on our website.
Great. And in chat, Vivian's entered these things. Okay, so the healthcare passport can have these a variety of sections in it. In here, there is an area for a brief medical history, and this would include for Brian, he would put in spina bifida and any past surgery and illnesses and medical issues. And for one of my family members, it would be autism spectrum, as well as other medical conditions. Then the current medications are important to list, including doses. And then a section about how the medicines are taken, to make sure they're being taken the right way. And then allergies are up here. I think you've got a pointer on it. And then these are the very important sections down here, is how explaining how I show pain if I'm unable to communicate it in the usual way, and indicating also if there's a low or high pain tolerance. So I always, when I go to the podiatrist, I always tell them that I am just like some people are dental chickens, I am a foot chicken because I had a bad experience once with a podiatrist who caused me some trauma. And so I'd have to indicate that I have very low pain tolerance for my feet. And and I might scream if I'm in pain, but other people might not be able to express their pain in the usual way, and might not even be able to identify where the pain is coming from. That's an important thing for doctors and nurses to know. And if the way a person shows pain is by whining or just squinting with their eyes or things like that, it's important to explain that. Otherwise, they may perform painful procedures and not realize that the patient is in pain. And then the last section, also really important because many doctors and nurses have no familiarity with disabilities, and they won't understand how to address distress, because they don't understand all the diverse ways that people respond and the diverse ways that work to calm them. And so, for instance, with one person, it may be that you could calm them by playing favorite music. For my family member, some kind of favorite food. A lot of people, a heavy blanket can help, like an X-ray lead jacket, that sort of thing can help. And so explaining that in advance is so important because doctors don't know and bad things can happen without information. Next slide. And support during visits. So during the visit, it'd be important potentially to explain to the healthcare provider what SDM is all about. Some physicians won't know and some nurses won't know about it. So explaining that would be the first thing. The supporter can provide moral support and explain the choices when the self-advocate asks for help. Helping facilitate communication when needed is another role for the supporter. It all depends on the level of comfort of the self-advocate in this visit. Making sure the visits are patient-centered is very important. It's very typical for doctors to turn to a family member, the supporter, and ask all the questions of the supporter instead of asking them of the self-advocate. That's a serious problem. And so it's necessary often for the supporter to say, please direct your questions to the patient, so that he or she recognizes that he or she is making the decisions. Um, let's see. And lastly, giving time to understand decisions. This is why preparing in advance is very helpful because most doctor visits end up very short and the physicians will be rushed on to move to another patient. And so it may work out to ask the doctor if they could go ahead to the next patient while you discuss it and think about it and then come back. That's a good option to consider so that there's time to understand any surprise decisions that have to be made. Next. Okay, and then this is one of the tools that often can be used for communicating if there's any difficulty communicating. Many people have uh, augmentative and alternative communication methods, and these are some simple ones here that a patient, for instance, during COVID, there were people with communication disabilities that were in the hospital, and the family wasn't allowed to be there. And so this kind of tool could be super powerful and essential to be able to explain to doctors what's going on. It could also be very useful for a patient that has to have their mouth covered or, in some kind of a feeding tube or a breathing tube or some other situation which doesn't allow them to communicate. So this is useful for all kinds of people, not just those with disabilities. So being able to point out where you have pain, whether something itches, whether there's headache, sore throat, or other symptoms like heart pounding or stomach upset. And then it's possible to type in, questions and answers through this typing pad over on the left side. So these are all very, very important things to have, especially in intensive care units. Next slide. So after the visit and following up, the supporter can also help there, and more than one supporter can be involved. Following the aftercare instructions can actually be complicated. It may involve calling for imaging or going to the pharmacy or following some kind of a lifestyle change and understanding those instructions can be the supporter can help with. So it's actually been studied and determined that SDM is associated with better health outcomes, that those who use it are better at following treatment plans, and overall their well-being and sense of empowerment is greatly enhanced. And next slide.
And this next slide here is our support framework. Again, like Dr. Deemer and Miguel and Brian were saying earlier, sometimes we have to do the forefront in educating our healthcare providers about the disability. And so the support framework is something we DVU came up with to kind of assist in using supported decision making in the healthcare field. And so it's spells out support, but it's seek information, use supporters chosen by the patient, presuming competence, providing accommodations, obtain permission, and role play with visuals and train others. And all of this can be given in a flyer to your doctor in advance to help them better know and better be prepared for visits with your loved one. And so all of the forms that Dr. Deemer showed there, as well as the support tip sheet, is available in the link that we just put into the chat for your prepare for your medical care. And then I'll pass it back to Dr. Deemer.
I just wanted to add one thing here, which I like this a lot. It's helpful to understand the obtain permission. Um, and that is because many individuals on the autism spectrum also have something called sensory defensiveness. And this means that they have um, that touch can be painful and perhaps shocking, and lights shining in the eyes can be painful as well, and even cause a meltdown. There's many things that neurotypical people do not find painful that people on the autism spectrum might. So loud noises that you might hear in an MRI, and the lights at a dental visit or a procedure room, cold tables, or a doctor. So before a doctor puts a stethoscope on the patient, they need to obtain permission. So any touch or contact of any kind, or shining a bright light, those things should may need permission, and that's something a supporter can ensure that is done. Okay, next slide.
And that was actually our
Oh,
last slide there. And so we'll go ahead and stop sharing the screen. But we now want to open it up for folks that may have some questions, may have any questions regarding supported decision making in healthcare for either Brian, Miguel, or Dr. Deemer before we go into our next presentation or next discussion of talking about living independently or living without parents. So please feel free to raise your hand or type in the chat any questions you all may have. Don't see any raised hands at this time. So um, if folks are typing questions into the chat, we can go back to questions. Yes, go ahead, Dr. Deemer.
I could just add another couple things while people are thinking. One of the reasons that this can be extremely important is in preventing conservatorship, because it turns out that when someone goes to a physician and it's determined that a major procedure is needed, the physician might determine that informed consent is not possible with the particular self-advocate. Let's say they have a communication disability and they completely understand everything but can't express themselves very well, and the doctor doesn't have the patience to listen. The physician may well tell family members that they have to get conservatorship, or tell the self-advocate that they need to get a conservator in order for the physician to feel comfortable that they are not liable for malpractice or even assault and battery if they proceed with a procedure without what could be challenged as inadequate informed consent. And so supported decision making can help prevent that entry into conservatorship. That's one of the sources.
And I see Gilda in the chat added in. I think it's important to add that we should start at a very young age to include the child in the decision-making process in healthcare.
Very true. And so often, as you know, it's not a patient-centered discussion, that typically the physicians talk to the parent when there's a child patient. And
Mhm.
I've seen some do a really good job. Some pediatricians do a great job talking to the patient, but definitely that would be great. There's another question. Um, is there a list of people who provide SDM that are paid? That's a good question.
Yeah, so
Maybe
the
Judy knows? No?
Yeah, you don't want to be paying anybody to provide anything related to supported decision making, I think it is completely fine for you to have some paid people, like a paid staff member or something like that, as part of the person's circle of support. But I actually think it's a terrible idea for you to pay someone to help you with a supported decision-making agreement or anything along those lines, because there are lots of people out there who will do this. But you, first of all, you can do it completely by yourself, and it doesn't require legal expertise, and you don't need to be paying anybody for any aspect of this.
Judy, I was just thinking, I wonder if the question is more for somebody who doesn't have any family members and just wants to find out if there's someone who could join them going to a doctor's visit.
Oh, so it's really a
But,
patient advocate which is a little bit different than I think of
but
somebody who's practicing supported decision making. So you're more the expert on that.
Uh, yeah, I see somebody wrote, for example, can you pay an LVN or RN who'd be better able to ask appropriate questions? Yeah, that is a really good question and a good point. It turns out, oh, and someone else already answered that Britt Bellwine at ACLU can help. In terms of getting a health professional to be a patient advocate, I believe that there are such things. They're called navigators in depending your insurance company may have these patient navigators. Ordinary folk even need them just to find their way through the medical system. And so I think there may be such a thing. If one looked online for patient advocate, you would have to try to separate that out from what Judy was talking about, which is somebody, that you pay to set up SDM. I see Mariana Guerrero is raising a hand, maybe has a comment on that. You're muted, Mariana.
Mariana, you should be,
Oh,
yep,
there you
there you
go.
go.
First, I wanted to say thank you for this important information. I mean, I wish I would have known this 20 years ago. Um, I currently help families and I go into meetings with the regional centers. And I notice that the regional centers really push for the conservatorship. Is there a training that the DDS can go back and train these individuals? Because one of the things that I've noticed is that I work with a lot of the Latino communities, and they kind of follow what they are told rather than learn the subject matter and kind of really get the information. And I've noticed that I would say 90% of the meetings, that is one of the questions. Oh, are you conserved? And then I have to jump in and be like, oh no, sorry, they're doing the supported decision making. And then they look at me and they're like, what is that? So, like you guys were sharing about how important it is to educate the medical, facilitators who help us or the doctors. I think the regional center should be one of the ones that is also educated, especially because, like I said, most families that I know really follow, oh, conserve. Yeah, I should conserve my kid, right? Yeah, yeah. And instead of asking the question. So is there I know Judy was saying no over there. I'm assuming not a lot.
Judy knows all about slapping the wrists of the regional centers. Yep.
Yeah, so let me try to explain to you that so there has been a concerted effort over the last year and a half to train a lot of people about supported decision making. There were grants given to a lot of different groups, including DVU and UCLA and others, to help build capacity, to do trainings. And DVU has trained healthcare providers, lawyers, judges, educators, teachers, lots of folks, and many self-advocates and family members. The one group that was never trained were regional centers. And that we obviously feel that's very problematic since we believe that regional centers are some of the biggest drivers of conservatorship. We know it's regional centers, teachers, doctors, lawyers. Those are the professionals. And then other parents are also drivers of it big time too. So the fact that regional centers haven't had official training is problematic. DDS has issued some some information about SDM. It's not very complete, and I wouldn't trust DDS to do it in the way that it should be. Anyway, one of the little things that people should know about regional centers is that they also can serve people, oftentimes taking away conservatorship from parents. It used to be much more prevalent, and there was a very big TV series, news series about it back several years ago, actually, when we were trying to get this law passed, which really it was called The Price of Care, and showing how people with IDD were getting conserved by their regional centers behind their backs. Um, and um, and since that time, DDS has had to commit in a big, like, public statement saying that they are going to release a bunch of their conservatorships and would provide training to their regional centers. Of course, we haven't seen that happen completely. And Mariana, I know you really well, and I would, maybe separate from this, I'd like to hear which regional centers are doing this more than others. Because I can tell you there actually are some regional centers who have made great improvements since the law was passed. And they do not now automatically um, sign letters to the judge. So something you guys should know that people with developmental disabilities served by regional centers have a different type of conservatorship than other people. There's something called general conservatorship, which people not served by regional centers get. And then there's limited conservatorships, which is what people in regional centers get. And the only way to get a limited conservatorship is to have a letter from the service coordinator stating to the judge that the conservatorship is needed. And the problem with regional centers is that they don't actually assess whether the person has capacity to make decisions with support before they sign these letters. These letters are generally form letters. 99% of them are form letters. And they're just like parent call says, I'm conserving my son. Can you send a letter? And the regional center says, yeah, not a problem. And it is a form letter that says, John Smith needs to be conserved. There are health and safety issues, and therefore we recommend to the courts that he is conserved. Like that is basically it. There are now some regional centers who are not automatically signing these letters, and they're now asking the family member, have you tried alternatives first? I'm not saying all of them are doing that, but a lot of them are doing, not a lot, a few of them are definitely doing that. And I'm hearing about it because I've heard the outrage of parents who are trying to conserve their kids being outraged at their regional center to ask this question. So I hear it from the opposite point of view as opposed to people going, yay, yay, regional centers, you're doing the right thing. So there are some that are doing a good job. And I'm clearly not all of them are. So we should privately you can tell me which regional centers are the most problematic and we can try to do some advocacy around it.
That's
Thank,
great.
thank you, Judy. Thank you, Mariana. And with that, we're going to continue on with our presentations. We'll go ahead and bring Jesse onto the spotlight here to talk more about living independently and living on their own. And so Jesse and I will kind of have a conversation, have some talk more about it. So Jesse, do you want to introduce yourself first?
Yeah, sure. So first and foremost, thank you for having me here and for everybody to be a part of the presentation and listening. I am a self-advocate. I had oraloproxia as a child, which I was able to overcome. I have ADHD, which affects my executive functioning, and that's impacted my ability to live independently.
Thank you, Jesse. So, Jesse, what was the process like when you shared that you wanted to move out?
It was The process was a little complicated. I did have some experience living away from home at first because I went away to college. And so, in that experience, I was able to understand the components of how to maintain the living room and living area, as well as how to deal with possible roommates. At the moment currently, I do not have any roommates. I'm living on my own. But because of that, the going back to the whole process, it was challenging for me because I had to show my parents that I was capable of doing household chores such as helping clean up the kitchen area when after a meal and maintaining the maintaining the floors by sweeping and doing maintenance. However, once when I was ready to move out, my parents were very hesitant in allowing me to do so. And one of the things that I wish could have happened was better and more communication and them helping me understand if I want to move out, there are certain components to that, which is being able to look for a place to live. I did not have that opportunity. And so I had to continuously ask them for support and live with them. And it wasn't until a apartment opened up at my parents' apartment complex that I was able to finally move in. And so my that was my process of how I was able to finally move out. Oh, Vivian, you're muted.
Thank you, Jesse.
Mhm.
And Jesse, what do you have to say to parents and self-advocates about independent living or kind of living without parents? Continuing on with your story.
Yeah, so I'm gonna separate that question and start with for the parents. I would say the biggest thing ask is to ask the self-advocate or if it's a caretaker to just ask questions to them and to guide them through the process. Because otherwise, what happened for me is they were doing a lot of things for me. And so did not have the opportunity to learn what would work best for myself. And so having that ability, and so just also allowing the self advocate or the other person to be able to make mistakes. Because if I'm not able if I'm not able to make mistakes, then I'm not going to be able to grow and learn what works best for me. But also if the parent is doing all the work for me, yes, exactly. We learn from our mistakes. And also if I'm not able to learn and everything is being told to me on how I should do things, it also makes me very uncomfortable to ask and seek the support that I need to be able to make my own decisions. So that's the advice that I would have for parents. And for self advocates, going back to the whole making mistakes, don't be afraid to take risks. Don't be afraid to take challenges to be able to challenge yourself because that's how you'll be able to learn and grow and develop what works best for you. Also, to be able to befriend and get to know your neighbors and the people around you. That's also very important because you never know when or how if you're in a situation if you need their help, they'll be more likely to be able to help you because they'll know your needs. And also for self advocates with independent living, it's very important to know the workers at your facilities. That way, then if you need to contact them, you'll be able to do so on your own. or with the help of whoever you have supporting you. But
Thank
something that, yeah.
Yeah, Jesse. And then just wanting to add on to that, kind of what challenges did you face, or what's an example of one challenge, and how did you work through that with your circle of support?
Um, so some challenges that I face is meal prepping, organizing, and just keeping my place tidy. And I'm not gonna say that with keeping my place clean that my place is an absolute mess. However, kind of it's difficult for me to be able to continuously make sure that certain areas are clean just because I'm constantly not moving, but I'm constantly moving from task to task. So sometimes I forget to do certain tasks. So that is the biggest challenge for me. And the way that I'm able to overcome that is by making sure that I have a timer on my phone that goes off to keep myself on track with my time management. So I'm completing a task, then I can move on and transition to cleaning the bathroom, then going and cleaning the kitchen, for instance. And so that's what I do.
Well, thank you, Jesse, for sharing your story with us. And now we'll pass it over to Judy and Michael to kind of talk more about living independently, but maybe from a different perspective.
Mhm.
Hi, everybody. Um, I'm Judy Mark. I'm the president of Disability Voices United, but that's not why I'm here. I'm here to actually talk to you as the mom of Joshua, who is practices supported decision making every day. And I'll hand it over to Michael for him to introduce himself, and we'll have a little dialogue back and forth. Go ahead, Michael.
Sure. Yeah, my name's Michael. It's a pleasure to be here. Thank you for having me. It's really my pleasure to talk about what supported decision making, what I know about it, and what I practice all the time. I got a degree in social work back in 2014, and I've been supporting people who have intellectual disabilities since then, even a little bit before that, in lots of different settings. And I've been in California in the self-determination, working in the self-determination program for the last three and a half, 4 years. Yeah, I'll just start saying some of the things, and Judy, I'll pass it over to you at some point, or if you want to, chime in at any point, please interrupt me. We've already talked about a lot of these things, but the two important, really, really important pillars that I see are presumed competence and dignity of risk. We've been talking about big decisions, which are really, really important, things that we can plan for, things that, and that's really, really important. What I invite people to do is to try to adopt those same things into, every moment of time that you can when you're supporting someone. Um, from my perspective, there are lots of opportunities to share information, present choices. What I have seen is that people live better and more meaningful lives when they get to decide for themselves what their time and their day looks like. And that's really where that's the environment at which people open up and broaden their own horizons. So a lot of times what I have seen is, families, whatever the stakeholders are, uh, you know, imposing a best decision, right? And it's understandable. There is a balance to be struck. If you're talking about something with immediate health concerns, it changes the landscape from something that, well, they want to spend their time doing what looks like, fun for them and great for them, but we think it's not fulfilling or something. what I see is you can set yourself up for failure trying to prevent someone from doing the things that they care about doing. Um, it requires a removal of some ego, which can be a huge challenge because we can so easily take for granted that we have this information. So one of the tools that I would offer someone is information. That I know that we've already talked about this a little bit, but the more that you can give information for people to have, uh, that that supports their decision making, and it creates an opportunity for them to make their own decisions. And you really want, it's things that don't work are punishments for making the wrong decision. That's never going to work. So you've got to get ahead of that and say, it's okay, whatever you decide to do. Here are some choices. This is the information that I have about this choice, and this is the information that I have about this choice. And if it's, an overarching, long-term goal or question that we're working on, thinking like, dietary needs, whatever, you know, really staying consistent in providing that information is a challenge. And, you know, everybody makes mistakes, which comes back to the dignity of risk thing. People should be allowed to make mistakes, whether that's you as the person providing support or the person receiving the support. Um, yeah, I'm moving pretty quickly. Do you have anything that you'd like
Yeah.
to?
Yeah, so let me make it actually real for the people who are watching this. So I have a son who's 29 years old who moved out of our home almost 2 years ago, May 7th, 2024. We call it Freedom Day in our household because it was freedom for both my son and freedom for his parents because he moved into a home with his sister. So we became empty nesters overnight. So it's freedom for everybody. Um, and obviously having so my son, I know people love whenever I talk about my son and his practicing supported decision making, people who've never met my son in their entire lives love to say, well, your son's not like my son. They love to make this presumption, even though they've never met my son. And I will just tell you that my son is in a different time with different parents would have definitely been conserved. He is a prime candidate for conservatorship. His verbal skills are very limited. He has a lot of significant learning disabilities on top of his autism. He has like significant safety concerns. If the house was on fire, it is unclear whether he would know to run out the door. He requires 24/7 supports on every part of his life, including hygiene, toileting, showering, all those kinds of things. And so he is the kind of person people like to say, your son's different than my son. I can promise you he is not. And what I what I can tell you is that when he was 18, or when he was 17, we were heading right down the path of conservatorship for my son. But I also, luckily, was friends with Linda Deemer, who you just recently heard from. And Linda was my sort of North Star on ensuring that my son lived his best possible life and talked to us a lot about supported decision making as an alternative to conservatorship. And I also was able to connect with a mentor of mine, an amazing man named Don Hoyle in Michigan, who is sort of the national expert on not conserving people, not putting guardianship over people. And so we made, after a lot of thinking, we made the decision, the unusual decision to not conserve our son. And this is way many years before the supported decision-making law got passed. So we had nothing to point to in law to say we practice supported decision-making with our son. to be able to say, because people would ask us all the time, where are the conservatorship papers? I'm assuming your son is conserved. And we have nothing in law to point to. For those of you who have not yet made decisions on this, you parents out there, you have now something in law to point to. Like we didn't have that. And the other thing I should tell you is that my son has a completely different last name than both my husband and me. My last name is Mark. My husband's last name is Ehrenbaum, and my son's last name is Ehrenmark. And he has a combined, completely fabricated last name. So we have all these things going against us. People, there was no SDM law. There's only conservatorship that people think is the option. He is a person who would very likely be conserved, and he has a completely different last name than us. And all these people ask me, like, what kind of risks did you put in place in you know, how do you protect him? And in fact, what we learned from Linda and from Dawn and from many of my mentors in my life is that in fact the dangers are much higher when a person is conserved than when they're not conserved. In fact, studies have shown that people who are conserved or who are under guardianship are much more likely to be abused in programs and in group homes in situations that than people who are not conserved. So there is something about conservatorship that when you tell doctors, when you tell regional center folks, when you tell school districts if they're still in school, or if you tell staff when they move out of the home that he is not conserved and he makes his own decisions with support, there is like an increased respect that my son gets because of that. It means that when he goes to the doctors are actually speaking directly to him and not to me. And if they ever make the mistake to talk to me, I immediately go ask him. And so it now, does this mean that my son can make all of his decisions easily? Definitely not. And especially as he moved out of our home 2 years ago, we are now dependent upon six staff that my son have round the clock, including Michael, who is the lead staff and helps to train the other staff. But we are now dependent on them to support my son in decision making when we're not there, which is the vast majority of the time. My son lives outside of our home, and we see him on Friday nights for dinner and on Sundays for brunch. Those are our set times that we see him, and then we might see him one or other, another time here or there. But my husband and I travel, we go on vacation, and there could be weeks that go by where we don't see him. And so we are very dependent on Michael and his colleagues who are on staff for my son to help support my son in his decision making. And so it could be very, very small decisions, which is, of course, where all decision making begins, is in small decisions. If people are not allowed to decide what they're eating or decide what they're wearing or little or when they eat, if they're not allowed to make little decisions like that, then how are they ever going to be able to make the bigger decisions? So you start with the little decisions, and and so it's like he gets to make those decisions. Does he make the right decisions? Definitely not. You will see him walking out of the house on an 85-degree day like today, wearing long pants and a jacket, and it is up to the staff to say, hey, Josh, it is like really hot outside. Have you thought about, maybe wanting to wear something that'll keep you cooler because it's super hot? And he immediately understands that and walks right back in, changes out of the pants, takes off his jacket, puts on shorts, and he's ready to go. Same thing with he might be wearing shorts and um it's like raining outside. It's like, Josh, it's raining outside. What do you think would be the best thing to wear because it's raining? He'll know what to do. Same thing. So those are the easy decisions. And I'll stop talking in a second and I'll let Michael give actual examples of these things on the daily life that they have together. But the harder decisions are on food. Just like everybody, we all struggle with eating healthy all day long. If none of you out there struggle with that, then I want to have a brain transplant with your brain. But most of us struggle with making good choices for what we eat. And all of us make bad choices when it comes to food and exercise and other things. And so we should not expect people with disabilities to be perfect in their decision making around food. So you should not be using like conservatorship as the way to, um, you know, give a force a person, an adult, to eat only certain foods at certain times because that's never going to work in the long term. And so it's been a process with my son to get him to understand like certain things, he drinks a lot of Diet Coke, which is basically burning holes in his teeth. And he paid for that by having very painful issues with his teeth. And he heard it directly from the dentist. This is the problem. When he goes to the doctor, we have the doctor talk to him directly about making healthy choices in food. And but ultimately, it is still his decision, just like it is all the rest, all non-disabled people's decisions to make poor choices and then suffer the consequences from them. But I'll throw it now to Michael about maybe how you guys handle that because I'm not around most of the time.
Yeah, so I mean to speak to dietary things, what works the best is when that information, those choices, those options are presented as early as possible. So like the beginning of the day when we're talking about where we're gonna go, Josh, we eat out pretty regularly, so we're getting too much food because that's how eating out works, and I have a hard time with it too. Is another thing that took me a while to really get on board with making, I have to make the same choice that I'm asking him to make, right? This is, some of these things are challenging. They're hard. And so these options are presented, because Josh understands that, why. And there's also other reasons, if you bring part of it home, then you get to eat that meal that you like so much later. So you get to have that meal twice. That's what I like to focus on more than this is a choice that's good for you, because we're putting a value on to what someone else's value structure might be, and that's why it's so important that it's ultimately his decision. Um, I've seen lots of different, not with us, but different situations where people say, staff are not allowed to, no one, they can't make unhealthy choices. They're not going to make unhealthy choices. Staff are not allowed to allow this person to make unhealthy choices. That's setting up everyone for failure, setting up the person, your loved one, for failure. That's setting up your staff for failure. And as a manager and somebody who's managing other teams, we've got a little business doing it now, you know, a lot of different people. I mean, these are like soft skills that it's really hard to know how to find the person that has those skills. Not everybody, lots of people go their entire lives without developing these skills, where you are giving the people around you in your life autonomy and freedom to make their own choices, and a helping hand in making those decisions. So, finding the right way to talk about that with your staff can be really, really challenging, and why I it's such a huge misstep to say, we're going to make the best decision for them, and we want staff to enforce that as well. What happens when you're making better choices and setting things up for success is like, how do we support the staff in understanding why we're doing this? And that's why this supported decision making training is so important. It's for people to start thinking about how important it is that we all get to make our own decisions in our lives. I just think, how are we doing on time? Do we want to open up for
Like another
questions?
minute. Yeah, one
Okay.
more minute. Mhm.
Okay. Um, I we all make mistakes. I've made plenty of mistakes. I made one just the other day trying to encourage Josh to make a good decision around some daily living tasks with folding clothes. And I was presenting him choices, but I was leaning in the choice. So there are ways to lead someone, and that's you want to look for those things and learn not to do those things. You're not giving someone really a fair choice one way or the other. People don't know what they don't know. You think, how are we going to help somebody grow if they don't want to try these things? So you push a little, and I found that you know Josh let me know. It's that it wasn't good for him, and I apologized because I made a mistake. And people, not everybody's willing to do that, but you can talk to people about how that's okay to do. Staff are oftentimes in this funny position where they feel like they know what the person they're supporting wants and they know what the family wants, and these things might be at odds. So give them space to talk about those things, to feel secure in making a mistake. You know, you've made them too. Everybody's made them, right? So it's those are important things to think about. And thanks.
Okay, Vivian, I don't know if there are any questions. We could talk more if there aren't,
Yeah.
but
There's one question that directly to Michael. It says, does Michael work full time with your son or other families as well that he leads?
This is a great opportunity for me to tell you about my little business, our business called SDP Staff Solutions. I say our because I have a partner. He's not here today. He's actually supporting Josh right now. But um, we've got a website. It's called sdp.staff. I'm sorry, that's my email. SDP Staff Solutions. I'll put it into the chat when I'm finished talking. And you can fill out a form. We provide management services for teams, and we provide hiring services. It's sort of the two branches of what we're doing. For hiring, we help you fill your gaps. We've also helped people who are just getting into the self-determination program hire entire teams. For the staff management services, there's a lot of different things that we do, and it could take me a bit to describe it, but we help you manage your team. So things that, you know, if there's ever any kind of scheduling issue, we make sure that someone's there. We can give you a handbook. We can help you establish guidelines for your employees. We can, mediate any kind of conflict and hopefully avoid those.
yeah, let me tell you why we as parents made this choice to have Michael be the lead staff, because I know many parents whose children move out of their home and the parents are still planning their social life. When somebody calls out sick, they call mom or dad. They have to, they're constantly still being part of their child's life in every aspect of it. Um, and let me tell you why we decided not to go this route. It is exactly because of supported decision making that we decided not to go this route. Because in the self-determination program, which by the way, the self-determination program and supported decision making are completely interconnected. And I am constantly seeing people on Facebook and other places talk about self-determination and say, can we use funding from self-determination to conserve our child? And it's like they're really an anathema to each other. They're polar opposites. Because no one can be truly self-determined if they can't make their own choices and they're conserved. So, so when we were thinking about like what's going to happen, because we started planning like 2 years in advance for our son to move out. Like it's not something like he's going to move out in 2 months. Like there was a lot of preparation work for my son. He needed to gain a lot more. It's not, I wouldn't even call them independent skills because my son is actually not independent on almost anything. But it's I would call it interdependence skills. Like I am much more into interdependence than I am into independence. All of us are interdependent. All of us practice supported decision making, unless you are like the genius of the world and literally can change the oil on your car and do like PhD level math and can also, play a sonata on the piano. Like everybody needs support on everything, and I certainly do myself. And so we decided, Michael is a very experienced manager of staff and of have worked with many different people, and it has been honestly so liberating for us as parents, which is great, but it is actually even better for my son than for us because I'm not going to live forever. My husband's not going to live forever. And we are now creating a wraparound of circles of support, of services, of people who support my son that do not include my husband and me. And I know a lot of parents go, "Oh my God, I don't know what's going to happen when we die." Like, I don't think about that. I literally never think about it. Like, I don't want to die. And so that's certainly not something that is imminently going to happen. But I never worry about that. And that's because my son's only 29, but I've been planning for what's going to happen after we die for 20 years, probably since he was 9 years old. And all of you should be thinking about who's going to be part of their circle of support when you die, not who's going to care for him, who's going to protect him. Because if the person has a strong circle of support that is nimble, that can be changed at any time, like they are the right people to be part of your child's life. So sorry, I realize it's 6 o'clock and I will give it back to Vivian to wrap up. Oh, you're muted, Vivian.
All of this was such an amazing conversation. So I encourage you all to join next week for our next session on finances and education to learn more. It'll be the same link, same time, same place right here, as well as our panel at the end of March to connect more and learn more. And again, thank you everyone for joining us today, and we hope to see you all at the next session.